The most common myth about robotic surgery is that it costs too much and takes too long, while in fact, many health systems have shown that's not always the case. When there's structure and leadership across executive, clinical, and operational stakeholders, hospitals can think strategically about robotics as a service line and dedicate appropriate resources to standardize the care they're providing patients. This results in less variability across the service line and ultimately reduces the burden among providers. Today, we'll hear how Northwell Health implemented such strategies to impact patient care and change the way we think about surgery moving forward. My name is Molly Gamble. I'm Vice President Editorial at Becker's Healthcare, and today I'm pleased to moderate this discussion. Let's start by having our panelists introduce themselves. Dr. Battinelli, I'll start with you.
Yes, hi, David Battinelli. I'm the Chief Medical Officer at Northwell Health. I'm also the Vice Dean at the Zucker School of Medicine.
Hi, and I'm Frank Cascio, Assistant Vice President, Program Management here at Northwell Health.
Terrific. Well, to get started today, Dr. Battinelli, perhaps you can share with us a bit about your initial goals when you invested in the Da Vinci robotic assisted surgery, and how have those goals changed over time?
Our initial goal was what it always should be, is quality patient care, and using advances, whether they be in some type of minimally invasive strategy or otherwise, embracing the science and trying to be at the forefront to deliver the highest quality care. With robotics, we saw the future. We knew that this would be quite a journey, quite a road, that there were some obstacles to overcome, some things that needed to be addressed, but that it was clearly the way of the future, and it was certainly what our surgeons believed was going to be the best quality care.
And this has been just such a remarkable year, and employee well-being has become a top priority for health systems throughout the pandemic, with high levels of stress among providers leading to burnout and then to turnover. Dr. Battinelli, how does Northwell manage this and attempt to reduce the burden that all providers are facing right now?
Well, here in New York, we were really in the eye of the storm with respect to the COVID pandemic. Our main message was to support our frontline workers, and the support they needed was primarily around being safe, and we did that through adequate PPE, personal protective equipment, and also making sure that the actual volume of care that they needed to deliver, despite rapidly escalating numbers, wasn't so great at any one facility, and we moved people around. We called it load balancing, and that together with being safe was able to help our providers really do what they had to do, which is give an unbelievable amount of care at the front lines. The patients needed it. They needed the support of the system. And we do that with everything we do. In robotics, for example, we have embraced our providers. We've listened to our providers who help us understand what's the best way for them to be able to do their work on the front lines.
Well, speaking of robotics, let's dive a little bit deeper into the program at Northwell. Traditional laparoscopy has been around for years, yet we haven't seen the adoption and shift of open procedures to minimally invasive like we have with robotics. What were the differences in robotics that made this idea of standardization of care delivery seem possible to you, Dr. Battinelli?
Yeah, again, I think we have seen a pretty remarkable shift from open to less invasive, whether you call it minimally or whatever. The point is to be less invasive so that you have faster recovery times, smaller scars, and hopefully equal or better patient outcomes. When robotics came around, there was a difference. It went from not just being minimally invasive, but the technology, the robotic arm, the kinetics, it really was a better way. You could reach into other places that you couldn't do minimally invasive. You had better equipment, and it really was a step up from minimally invasive procedures. So robotics, as was in the industry, other industries who embraced it, whether it be computer technology, mechanics of any sort, the robot is remarkable, and we needed to figure out a way to harness that energy.
Mm-hmm. Frank, let's turn to you, because Northwell became the first network of excellence for robotic surgery, which is no easy feat. Can you talk about the composition of your robotic surgical team and how your steering committee initiatives made that possible?
Well, I think it really began with our executive leadership team, who charged us with creating a program that was rooted in superior quality outcomes and patient experience. From there, we really wanted to develop a robust committee dedicated to quality, credentialing, operations, and education. I think those 4 pillars were the foundation of our success to be able to work towards a Network of Excellence designation, because regardless of which pillar, as I like to describe them, patient experience, quality, and specifically standardization was at the core of what we've done here. So in that regard, a lot of our efforts were around standardization. So it made us going from 1 center of excellence to 2 to 8 to a network, all that more achievable.
Let's take a deeper dive into those domains, those 4 pillars you mentioned. First, credentialing. Although it might not be the most exciting topic, it seems as though that was really critical to your success. Can you talk a bit about what this looked like for Northwell and how credentialing impacted your program?
Yeah, it certainly was. When we began looking at the delineation of privileges, regardless of specialty, one of the things that we realized was there was consistency, but it wasn't good consistency. We had a single line item that delineated robotic surgery privileges. And as we know, we can do amazing things with this technology. And we found that we really needed to delineate the tiers of complexity for these types of procedures accordingly for all of our specialties. So we've done that. We've gone from just 1 line item of robotic surgery to 4 tiers of complexity depending on the specialty. Another really good thing that we've done with medical staff services alongside our committee is really take an effort to leverage the medical staff office and the delineation of privileges to be incorporated within our strategy. So one of the things we found very valuable within Northwell was kind of creating a tertiary versus community strategy, where some of the more acute cases, we wanted to really open that up for our tertiary facilities, where some of the more community-focused facilities, we wanted to open up the lower complexity procedures to help drive that volume there, thereby opening the access for some of the higher complex cases to be performed at our tertiary facilities.
Well, speaking of access, we've seen site of care strategies really accelerate thanks to the pandemic. Dr. Battinelli, how were you able to scale this out, and has the delineation of privileges, like Frank mentioned, how has that helped ensure good outcomes across the whole system?
Well, we track our data across the organization. One of the features of Northwell is that all of our hospitals and our ambulatory facilities are owned assets by the organization. So we can freely move things around, and we can also do similar privileging and credentialing across the organization. One of the big advantages there is that place A can look at places B, C, D, and E collectively in terms of the data to be able to decide on whether that person is adequately privileged and credentialed to do certain procedures. During the pandemic, we had to move our surgeons around all the time. We had to move a lot of people around into the different ICUs, et cetera. But we were well poised to do that because of the governance of our organization.
I'd like to now talk about quality, because without quality, this strategy goes nowhere. So measuring quality can be sometimes a challenge at first, but Frank, can you talk us through how your evolution of using data for strategic decision-making, how that has evolved and what that looks like today? How did you organize data in a way so it's actionable?
Sure. Yeah, that was a primary charge that we were given by our executive team, was to demonstrate superior quality outcomes. So first and foremost, we really need to understand, well, how are we collecting this information? And we are currently leveraging this given the size of Northwell with our billing data. And in the beginning, it was a little bit difficult because some sites were coding robotics under ICD-10, some were using CPT codes, ICD-10 procedural codes. So once we had an understanding of how each facility was documenting their procedures, we were able to take that inventory and really work with the sites to have consistency about how we're documenting our robotic procedures throughout Northwell. So giving us the intelligence to even understand volume was baseline number 1. And then really what we wanted to do is overlay that with some of the quality information. So we worked very closely with our clinical leads as part of the quality subcommittee to identify ICD-10 codes that would indicate that an intraoperative, postoperative complication occurred. So really starting to understand the intelligence of how robotics was with respect to patient outcomes was essentially a priority number 1 for our committee here. So once we had that intelligence, we were able to really start to identify where the areas of opportunity were, which surgeons we wanted to partner with to elevate through our Bioskills Simulation and Training Center. So that was priority number 1, is understanding volume throughout the facility and then overlaying that with the context of how is our quality. particularly amongst the modalities. So that was another component. We wanted to understand how robotic quality was, but we also wanted to understand how that compared to our laparoscopic modality as well.
Mm-hmm. And that type of actionable data is what really enables evidence-based change management, which sounds like is a cornerstone of the program at Northwell. What areas do you track to help reduce variation in your program, Frank? And how do you identify outliers and work with the care team to improve upon those metrics?
Right. So one of the things that we've done as a health system is we realized we needed to make the investment in our training facilities, right? Standardization of care, how you're treated at one facility needs to be the standard that you would regardless of what facility you're going to for your care. In that regard, having the intelligence to understand where the opportunities exist, whether it be operational efficiencies or quality efficiencies, we wanted to be able to offer a remediation through training internally here within Northwell. And we've been able to do that in parallel using the strategic insight gained from our data to help provide the resources necessary to our care teams and our physicians to really demonstrate the superior quality outcomes we believe this robotics program here within Northwell can demonstrate.
Well, great insight so far on highlighting some of the work that goes into providing excellent patient care with this program. But one part we haven't talked about so far is payers. You're tracking all the data now. Dr. Battinelli, can you share how you've engaged with payers to demonstrate the outcomes you're achieving and the impact that has had on your service line?
Yeah, sure, but first, I want to say that Frank's being humble in terms of the amount of work that he's put into this. You know, this executive committee is charged with making sure that the dyad of the clinical people and the operations people are working side by side to make sure that we can figure this out. So he's got an enormous relational database. And so we can show to a payer or to anybody, including transparency across the organization, single surgeon who may have a different outcome in terms of efficiency, complications, time, et cetera, from one facility to another, and then we can correct that. And so we've been able to extract whatever data the payers needed to be able to understand that this is an improved process that has an outcome that patients want, and we are arguing that the payers need to provide. This is not an extraordinarily expensive thing. This is a high-quality operation that when you get it right, you understand how to engage a first assist program, keep your ORs moving, decrease the amount of time, increase the standardization, and have great outcomes. It's very little that the payers can push back on. Mm-hmm. At Northwell, we have a recurring symposium where we bring in payers, potential referring providers, other organizations to see what the cutting edge advances are. With robotics, we spend a lot of time working with the payers, mostly because they hear the rumors, they hear the costs, they hear the inefficiencies, they hear other things, but they don't understand how we have solved for some of those things. So we have some of our high quality providers demonstrating, showing things, even some things as simple as some of the work that Intuitive has done with showing just what the technological opportunity is for the robot, what the robot can do that the provider can't do. And we hear this from the providers themselves. So again, there's a lot of myth out there, and then there's some reality. We need the providers to know exactly the truth about what's going on inside Northwell.
And I think one of the other unique opportunities at this symposium was really just having the technology on hand. Dr. Battinelli alluded to it, but it was an interesting concept to have some of the payers sitting on the technology, going through the simulation, a live augmented reality hernia procedure. I think that really gives insight into exactly how this technology can advance care for the patients.
Well, Frank, let's turn back to you to talk a little bit more about operations, because standardization, of course, starts in the OR with the robotic instrumentation each surgeon is using. Can you spend a moment talking about your lean instrument pilot work?
Sure. I mean, Dr. Battinelli had just touched upon it. We also made a significant investment within our first assistant program. In fact, not a new acquisition of a technology is always accompanied with a first assist as part of the business plan for that. We've recognized the value they bring to really leveraging the standardization goals that we have as an organization. And I think one of the other truly unique things about Northwell is just our size. We have 23 hospitals, 13 of which have the robotic technology within it. So we have the ability to understand what best in class looks like and being able to leverage that and bring it to all of our facilities to ensure that the care that we are providing is not only consistent, but superior.
Mm-hmm. We've talked about operations, credentialing. Let's talk now about some of the education and training that you had mentioned at the top of our conversation, Frank. It appears communication and a really collaborative approach has led to your process for seamless and successful adoption of robotics. Can you talk about your phased implementation training program and the impact that you've seen as a result?
Yeah, I think a lot of this goes to the collaboration and partnership we've had with Intuitive Surgical. We're able to quickly identify who a potential candidate is to be trained on the technology. Having that information allows us to partner with them, the local chair, the surgeon, him or herself, and really establish what best in class looks like and agree that we are all in on achieving these outcomes. So having that ability to partner with them allows us to identify the candidates that should be moving towards this modality in a timely fashion. And then bringing into the medical staff component of this, one of the things that we've really tried to do is as we identify a surgeon that is looking to become trained, we try to align that training date with when their privileging would go into effect. What we really wanted to do is mitigate the time difference between when a surgeon goes for training to when they can actually get onto the technology. So I think it's really twofold. It's about establishing a good cadence with Intuitive Surgical, identifying the candidates, making sure that we're all looking towards the same goals of achieving all-in success, and then timing that with medical staff services so that we're able to allow for that practitioner to go on to the technology immediately after getting trained.
Mm-hmm. Dr. Battinelli, let me check in with you as well on this point, because you all have pulled together quite an amazing Bioskills training facility. How has that allowed and how has it helped with the standardization of care across Northwell as you've seen it?
Yeah, the Bioskills facility with 24-hour access to the robot and simulation technology certainly provides an opportunity for additional practice and refining techniques and being prepared to get to the OR. But it really dovetails into our overall quality picture. You know, one of the differences with robotic surgery is that there's a digital fingerprint going on in the OR that simply didn't happen before, including the fact that we videotape all of our robotic procedures, we have them analyzed, we feed back to our practitioners, and we have technology within our ORs where the entire OR is videotaped. So that really helps us understand efficiencies, our first assist program, the technological support that our providers need, the additional training that any provider does need. So it all works together, and again, it's a huge advance beyond what we were doing with traditional open procedures with minimal monitoring, and all the feedback we had was based on what somebody said they did versus actual real data.
Mm-hmm. And Dr. Battinelli, as we wind down here, when you think about long-term sustainable growth, what do you consider when it comes time for incremental system acquisitions?
So it's clear that this will be a growing technology. There'll be advances in robots. There'll be acquisition issues that we need to work with, and there'll be expansion into other areas, whether it be inpatient, ambulatory, or others. I think it's the sharing of our data and our experience that helps us plan forward, and looking at some creative ways to work with companies such as Intuitive to be able to have what we need, understand what its lifetime is, understand what new technologies are coming, and what's most appropriate where. Again, we were an early adapter. We'll continue to do that, but time will tell. We learn as we go.
Well, thank both of you for this really interesting conversation about your success and what drove that success. To close, I'd love for each of you to provide some of your final thoughts and share what you're most excited about, what you're working on, what's next for the Northwell Robotics service line. Frank, can I start with you?
Sure. Yeah, if I can leave any parting knowledge to this group, it's really determine what your pillars are. The pillars here were very clearly defined early on by our committee, and every single participant worked towards those. I think the overarching goal is to provide superior quality outcomes and experience for our patients. So every pillar that we had, that was a core tenet of it. I think that was been critical for our success here. And I think aligning your clinical operational arms to be one and function as a team in the same direction, aligned on the same goals and the same vision, are critical to the success of a program. Dr. Battinelli mentioned it. We were an early adopter to the technology, and we're continuing to advance our program, whether that be bringing on incremental systems, looking at the new SP technology and how we can incorporate that with advancing care throughout Northwell.
Sure. Thanks, Frank. Dr. Battinelli, anything you would add to Frank's remarks?
Yeah, dovetail onto a couple of things. And I think sometimes people are afraid to engage the providers, the clinicians, because there'll be pushback or there'll be too much conversation. But, you know, what we did was we said, listen, we will grow this program if you help us solve the problems, if you help us figure out how the delineation of privilege and credentials should be so that it's a high quality program, if you help us get past the cost and the length of time in the procedures and we can trim that down. If you partner with us, we will grow this program because we believe it's a quality program. We believe that there are better outcomes. We have some obstacles we have to deal with. It's reality. We don't want to solve those issues. We want the providers to solve those issues. And again, as Frank said, we put that committee together, working with him in operations. They were able to figure it out, and they continue to figure it out as Frank feeds them the proper data.
So much of it comes back to those 4 pillars that you had defined and laid out for us, Frank, and then also the collaborative nature of the program, as you described, Dr. Battinelli. I want to thank both of you. It really has been a pleasure speaking with you and learning about your program more so today. So thank you for joining me and thank you for your time.
My pleasure.
Of course, thank you.